Great, and whoever's going first can start to share their screen.
Go first if you want, Rachel.
Perfect.
Okay, sounds good. Sure.
Great. And yes, so welcome everyone. We've got a nice crowd here today, and of course people will go online afterwards to review and to watch the presentations, which is a wonderful thing that we can do. So we have two presenters today. Thrilled that Marie Somerville is here, a postdoc fellow. She's going to be talking about nutrition care for pre-diabetics. And our second presenter is Rachel Ollivier. She is a PhD candidate in nursing, and she'll be talking about postpartum sexual health. So I will turn it over to you, Marie, and you have half an hour to present, and we'll have a bit of time for questions and comments. So over to you.
Right, thank you. Hopefully you can hear me. Okay. So my name is Mari. Thank you for attending my presentation today. I'm a postdoc fellow at Dalhousie University with the Strengthening Transitions in Care Lab. And today I'm going to be presenting basically my whole PhD project, which was looking at nutrition care for prediabetes in the Australian primary care setting. And I conducted this research at Griffith University in Queensland, Australia, with the Healthy Primary Care team. So before I begin, I just want to give you all a brief background on my research journey and how I arrived at my topic. So after studying and training as a dietitian here in Nova Scotia, I continued my academic journey into a master's in public health. I then worked for a period of time as a dietitian in the primary care setting, and I found that I was seeing a lot of patients with chronic diseases. But with my public health knowledge and background, I knew how important chronic disease prevention was. So I started wondering, why am I only seeing people once they've already got to that chronic disease stage? So with that, I continued my academic journey into a PhD in Australia, where I aim to explore this idea of chronic disease prevention in the primary care setting. And I specifically focused in on type 2 diabetes. So as most of you in the audience have a background in health, I'm sure you're all aware of the implications of type 2 diabetes, but just briefly, in Australia, type 2 diabetes impacts about 1 to 2 million people. And each year, about 8,000 cases of kidney disease are associated with type 2 diabetes complications. It's estimated between 11 and 33,000 heart attacks happen each year in Australia due to type 2 diabetes. And over 4,000 limbs are amputated every year as a direct implication of type 2 diabetes complications. And over a 20-year period, it's estimated that around 700,000 cases of diabetic retinopathy are a result of type 2 diabetes in Australia. And along with these medical complications, it's estimated that close to $15 billion are spent every year in Australia alone on direct and indirect healthcare spending related to type 2 diabetes. So with all of this, we know that type 2 diabetes is preventable, and prediabetes provides an opportunity for prevention. So prediabetes is an elevated state of blood glucose levels that precede type 2 diabetes. And in Australia, between 2 and 4 million people are estimated to have prediabetes today. But we know that if we provide diet, exercise, and weight management support at the prediabetes stage, we can prevent the onset of type 2 diabetes in the majority of individuals. And this evidence has gone on to inform international and national practice guidelines, which suggest that healthcare providers discuss lifestyle recommendations with patients as the first line approach to prediabetes management and type 2 diabetes prevention. So even though we have all this knowledge about how to prevent type 2 diabetes by intervening at the prediabetes stage, I wanted to find out whether we're actually applying this knowledge in practice. So I wanted to understand how people with prediabetes are being supported by us as healthcare providers in the primary care setting. To answer this question, I conducted my research using a multi-methods approach, and I conducted my research over 4 phases. I aligned this work with the IPARIS framework, which is the Integrated Promoting Action Research in Health Services, and it's a continuous cycle of 4 individual pillars: innovation, context, recipients, and facilitation. This is briefly my overview of the studies that I conducted across my PhD, and I'm just going to really briefly provide you all with the findings from each of these studies and then an overall summary of what I found. So in the first phase, I conducted an integrative review, which aimed to synthesize the literature on healthcare providers and patients around their knowledge, attitudes, and practices for nutrition and prediabetes. This involved searching 6 databases for nutrition, prediabetes, and primary care. And I included both patient and healthcare provider populations in my search. And I also included qualitative and quantitative study designs, as an integrative review allows for that mixed study design synthesis within the review. So I included a total of 26 studies, and I identified 5 common themes throughout the literature. The key takeaway message from this study was that there are contradictions between how patients were reporting that they experienced nutrition care for prediabetes and how providers were saying that they provided nutrition care for prediabetes. And none of the studies in this review were from an Australian primary care setting, so I wanted to further investigate this topic in a local context. To explore patient recipients in more detail, so I conducted a mixed method study aiming to identify characteristics and experiences associated with receiving a prediabetes diagnosis in Australia. And this study involved a secondary analysis of the 3D study, which is a longitudinal study that was conducted across Australia with adults who were recently diagnosed with type 2 diabetes. And this cohort were interviewed at 3-month intervals across a 1-year period, and we collected various data relating to dietary intake, anthropometrics, and demographic details. During the baseline interview, we asked all participants whether or not they'd ever been told in the past by a healthcare provider that they had prediabetes. So with this baseline data, I compared individuals who had versus had not been told they had prediabetes. I then interviewed a subsample of these participants from the prediabetes diagnosis group to better understand their experience of receiving that diagnosis. So of the 225 participants in this study, 100 people reported that they were told by a healthcare provider that they had prediabetes. And after I compared all the variables between the 2 diagnosis groups, so those with prediabetes versus those without prediabetes, I found that there were actually very little differences between these 2 groups. And this is just a snapshot of some of the variables that I looked at. And as you can see, the only significant findings or differences between the groups were in smoking status and satisfaction with a dietitian. So significantly more people were current smokers in the no prediabetes diagnosis group compared to the prediabetes group, and significantly more people from the prediabetes group reported being satisfied with a dietitian interaction compared to the no prediabetes group. So I then interviewed participants from the prediabetes diagnosis group to better understand their experience of that prediabetes diagnosis and to understand the nutrition care that they received following the diagnosis. So I interviewed 20 participants in total, and the interviews resulted in 3 themes. The first main theme was around experiencing the prediabetes diagnosis, And participants stated that this experience was very confusing and vague, and often the term prediabetes wasn't even used. The second theme related to receiving nutrition care following the prediabetes diagnosis. And again, people said that this was very unclear, with limited nutrition advice being provided, and oftentimes it was contradictory advice to what they had heard from other healthcare providers or from what they'd read on the internet or heard from friends. And the final main theme from this study was around reflecting on the journey from prediabetes to type 2 diabetes. So participants tended to compare these two diagnosis experiences, saying that once they had gotten to the type 2 diabetes stage, they had a lot of support from healthcare providers. They were given referrals to allied health support. They had access to the National Diabetes Services Scheme. And this was in direct contrast to the pre-diabetes experience, where they weren't really given any support at that stage. And participant 2 here says it really well, in that they wish that they had the same information given to them back when they had pre-diabetes, because they could have made those changes years earlier. So the key messages from this study were that fewer than half of individuals from the 3D study were told that they had prediabetes, which is concerning considering that all participants would have progressed through the prediabetes stage before getting type 2 diabetes. The second key message was that people seemed to receive a vague diagnosis of prediabetes and inconsistent nutrition advice following this diagnosis. And finally, there doesn't seem to be very many patient characteristics associated with receiving a prediabetes diagnosis, which led me to think that maybe it has more to do with healthcare providers and something to do with their characteristics as to what's triggering them to tell their patients that they have prediabetes. So with that, I wanted to further explore healthcare providers, and so I conducted another mixed method study, which aimed to understand provider practices and perspectives on providing nutrition care to people with prediabetes. This involved a retrospective chart review and qualitative semi-structured interviews with GPs and nurses in one large urban primary care practice that was located in Brisbane. So this is a flow chart of this study. And as you can see, a potential pool of 10,000 patients from the study site were screened for eligibility to be included in this study. And so I excluded people based on their prediabetes diagnosis status based on blood glucose levels in their charts, as well as being an adult participant and being an active patient. So I included a total of 47 patients in this chart review. So with these 47 patients, this related to 1,096 individual consultations or chart entries that I analyzed to identify how often diet and nutrition was reported in chart notes. And this study was conducted over a 1-year period. So here's just a presentation of the frequency of how often diet was reported in patient charts. And as you can see, based on number of patients, majority of people did have diet reported at least once across that 1-year period in their chart notes. However, when you look at the percentage for consultations or individual chart entries, diet wasn't actually identified that often. Only 8% of chart notes had any mention of diet or nutrition. And 1% of patient consultation notes had a mention of a referral to a dietitian. So I wanted to better understand these practice behaviors by speaking with the GPs and nurses in this large practice to better understand their reasons for talking about diet or recording diet in their patients' chart notes. And this The interviews from this study resulted in 4 main themes. The first was around providing lifestyle recommendations to patients with prediabetes. And all of the healthcare providers said that this was their initial approach to managing people with prediabetes. They saw it as really the only way that they would manage someone is to provide that diet, exercise, and weight management support. However, people also said that the ability to provide this nutrition support really depended on the competing priorities of that patient and the time that they had in the consultation to allocate to talking about diet and prediabetes. And as you can see, participant 3 said that, I hoped I would have talked about diet at least once, but it wasn't coming up often in the chart entries. The third theme related to referring patients for further diet support, and people said that this tended to rely on funding and the perceived patient motivation of actually going and accessing that additional dietary support. So I forgot to mention, but this study practice was located in an area of low socioeconomic status. So the healthcare providers in this practice said that unless this extra dietary support was provided for free or subsidized in some way, they didn't feel that their patients would be able to afford to go see a private practitioner. And finally, people said that they wished that the healthcare system was better set up to incentivize this preventive type care rather than incentivizing treatment of chronic disease. Because people clearly wanted to be able to give that nutrition support to their patients, but there was clear challenges or barriers built into the system that wasn't really allowing them to do this. The key takeaway messages from this study was that diet appeared to be initially discussed with patients who met the prediabetes diagnostic criteria, but limited follow-up and continued nutrition support was clear from the interviews and the chart review. And secondly, GPs and nurses really wanted to provide this comprehensive prediabetes care, but they're restricted in their ability to do so. So with these first 3 studies, it was clear that patients wanted to receive nutrition care, providers wanted to give nutrition care, but the healthcare system didn't really offer a clear pathway for people to get the care that they wanted. So for my final study, I conducted a qualitative study with health consumers to identify a way or to identify their preferences to inform a novel health service delivery model that meets their needs. And this study involved semi-structured interviews with health consumers from national and statewide consumer health forum groups. And I included 25 people in the interviews of the study. People ranged in age from 19 to 78 and had a variety of backgrounds in terms of chronic disease status. And 5 themes were identified in this study, which generally related to the who, what, where, when, and how of nutrition care preferences. And health consumers wanted to receive nutrition care from qualified providers. They all spoke about nutrition as being important, and they wanted to receive it in a way that meets their individual needs as a patient. People also spoke about wanting nutrition care to be free or low cost, and so that it could be available to everyone despite their ability to pay. The 4th theme related to having nutrition care services that were conveniently located, such as attached to a GP clinic in the community. And finally, health consumers wanted nutrition care to be offered frequently and across the entire lifespan. From this study, it was clear that people had preferences for receiving nutrition care in primary care, but these didn't align with the current nutrition care model that exists in Australia. So therefore, a new nutrition care model should be developed in order to meet the needs and preferences of patients. So in summary, I found throughout this body of work that patients and providers are really on the same page when it comes to nutrition and prediabetes. And I think healthcare providers really want to give that nutrition care and prevention to patients who meet the criteria for prediabetes. And patients also want to receive care at the prediabetes stage so they can avoid the complications associated with type 2 diabetes. But it's also clear that the primary care system in Australia is set up in a way that's really incentivizing treatment of chronic disease rather than prevention. So a new model of nutrition care that really emphasizes low cost, accessibility, and prevention while meeting the needs of patients is really needed. Thank you.
Thank you so much, Marie. And we'll open it up to the audience for questions, comments. That's a huge study, or studies, I should say, that you did. Very comprehensive, very, very impressive, and quantitative and qualitative. Anyways, I'm going to let the audience ask their questions first. Yeah, feel free to jump in. Go ahead, Marilyn.
Yeah, hi, Mary. Thanks so much for this. In your findings there where the healthcare providers, in other words, they weren't satisfied with the information that they were getting out to individuals, I assume nutrition related, was that because they themselves were not equipped to do it, or time, or both?
I think it was a bit of both. And the GPs and nurses that I spoke with, like they ranged quite a bit in terms of years of experience. And I felt like the more experienced ones were definitely a bit more on top of the information around preventing diabetes. And I think there was a little bit of uncertainty in terms of nutrition and the specifics around nutrition recommendations, but people generally felt they could give the basic recommendations, but it was really more about time. And they would say, you know, someone comes into my clinic or to my office with pre-diabetes, but they've also got, you know, obesity or depression and all of these other things that I'm trying to deal with, and pre-diabetes is kind of the last priority for them. So I think it was a bit of both, just not having enough time, competing priorities, and having enough nutrition information or recommendations to provide basic recommendations, but probably not much beyond that.
Thanks, Mary. You just reminded me that in your talk, because this was set in Australia, that it sort of made the news within the past week that the country that where cigarettes are have the highest cost in the world is Australia. And I'm wondering, there's got to be a link between the boost in the cost of cigarettes and chronic illness, in particular diabetes, maybe.
Yeah, I hadn't heard that, so it's really interesting.
Yeah, the most expensive is Australia, followed by New Zealand, followed by Ireland, I think.
Okay.
Yeah. Thank you.
Thanks.
I see Allison's hand up.
Hi. Hi, Mari. Thanks for the presentation. It was great. And I agree with Megan that it's clearly like so much work. So I thought it was really interesting to see how it all came together. And I kind of may have missed part of this, but I was wondering, you had kind of spoken a bit about a 3D study that your study was kind of a part of, and I was wondering if you could speak a bit more about that.
Yeah, so that I probably skimmed over that slide a bit quickly and didn't give a whole lot of detail, but the 3D study was a study that was conducted at Griffith University with people who were newly diagnosed with type 2 diabetes. And we essentially phoned participants every 3 months over a 1-year period following that initial diagnosis of type 2 diabetes. And what I did was I used that baseline data to see, to just compare those baseline demographic, anthropometric, and health service interaction data for individuals who said that they had previously been diagnosed with prediabetes. So that was one of the questions that we asked in the baseline interview with the 3D participants was, has a healthcare provider ever told you that you have prediabetes or impaired fasting glucose, borderline diabetes? And based on if they said yes or no, I categorize people that way. So yeah, so I guess the 3D study is bigger than my study, and I just use some data from the baseline interview from the 3D study.
Cool, that's great. Thanks.
Thank you.
Great. And does anyone else have comment or question? Let's see. You did a lot of semi-structured interviews, and I'm wondering if there was any particular methodology you used. Was it a qualitative descriptive or interpretive?
Yeah, so I guess in total I did 3 qualitative studies. So my last 2 were qualitative descriptive. So the one with healthcare providers, I was really trying to, I used the chart review data to inform my questions with that one. And then in my final study, I was really getting people to describe what they wanted rather than like a lived experience. So that was also qualitative descriptive. But my second study with patient participants, that one I used a phenomenological approach because I was wanting to find out, what was your experience when you were told you had prediabetes, and getting them to talk about that lived experience.
Yeah, very interesting. And were people pretty chatty when you interviewed them?
Yeah, I feel like the patients were very chatty compared to healthcare providers. It was a much more succinct response when I spoke with providers. But yeah, the patients had a lot to say, which was great.
Yeah, fantastic. And Keisha.
Hi, thank you so much for the presentation. I don't really have a question, more of a comment, and I'm just sitting here in awe. I just think your study is so beautiful, and just the way that all of the complexity comes together. I just thought it was really, really well done. I'm just, maybe if I could throw in a question of around like the process of it all, like bringing it all together. But even then, I just feel as though that's such a large question to ask, and to break it down, it might be challenging. So I just admire your work. Thank you.
Thank you. Yeah, I don't know how to comment back on that, but I guess thank you so much for that comment. And I guess, yeah, summarizing it, it was definitely a lot of mind mapping and just trying to tie everything together, because it was interesting because it was really the same things were coming out in every study, and it was just this common gap in every single study where it was people just couldn't get the care that they wanted, and like it was just so clear by the end that it was really more to do with the healthcare system, and it wasn't, patients weren't trying to get the care, it wasn't that providers weren't trying to offer the care, it was just the system was really restricting that preventive type care, I found.
Great. Okay. Well, thank you so much for your presentation and sharing, and great comments by the audience too. Okay, so we will turn it over to Rachel now. And if you'd like to share your screen, Rachel, you can go ahead.
All right, sounds good. Thank you so much, Megan. Let me just get it up here. Okay, is that looking okay for everyone?
Yeah.
Great, thanks, Julie. All right, so I'll be, I guess, presenting on my doctoral thesis. So for those who don't know me, my name is Rachel Ollivier. I'm a PhD candidate in the School of Nursing, supervised by Dr. Megan Aston, who is kind of here today, and Dr. Sherry Price. I'm also a registered nurse in various areas of care, primarily sort of acute care settings and women's health. Yeah, and so this is my first time presenting my findings, which I am so excited about. Yeah, it feels still strange to be at this stage a little bit, and I know you know, so many of you here today have seen me through every process of it. You've been in courses with me, or you've seen me talk about this dozens of times, and now, yeah, now I have kind of the findings ready to present. So yeah, definitely very excited. So without further ado, we'll get into it. So just my presentation outlined, we'll go over the background, aims, purpose, and methods, which will be somewhat repetitive for some of you who've again, you know, seen me through the past few years. And then I will explore my results, the significance, and then we'll have a question period, hopefully about 10 minutes for that. So sort of quickly to go over the background, again, you know, a lot of this presentation I've kept just the slides very simple, because yeah, I want to focus on the results and sort of talking about that. So, you know, in terms of background, you know, the literature is present in terms of, you know, postpartum sexual health, and a lot of what has been done has focused largely on physical aspects of sexual health, or, you know, sexual health as it pertains to sexual activity, you know, usually within relationships. And so, you know, with that, it's important to understand sexual health after birth in physically focused ways. We know that that is important for, you know, for postpartum folks. You know, so pelvic pain, pain during sexual intercourse, all those things, you know, certainly impact health. And that's, you know, kind of where a lot of it has stemmed, is from other kind of fields that, you know, have sort of biomedical focus, or focus in psychology as well, and looking at, you know, sexual relationships and sort of other facets in that way. The World Health Organization sort of is what I, you know, pin here in terms of the definition of sexual health. So this definition was first created in 2006 and remains active today. However, it has gone through several iterations in the past few decades that, you know, have at times prioritized different, you know, aspects of sexual health, whether it was, you know, set of sort of sexual safety in terms of, you know, biomedical focus, and again, an epidemiological focus of, you know, trying to prevent sexually transmitted infections, to then moving to a more, you know, I'll say holistic or well-rounded definition of sexual health. So, you know, I think it's hard to say that, you know, to get really the, you know, the perfect definition, but the WHO defines it as a state of physical, mental, and social well-being in relation to sexuality. And that requires a positive and respectful approach to sexuality and sexual relationships. So this is kind of, you know, what I have as a focus, just to, again, you know, compare and contrast, you know, what's similar and what's different in terms of my research and situating that. So as I said, there's a dearth of literature exploring, you know, emotional and relational aspects of sexual health, especially during the postpartum period. We know it's a period that can be, you know, rife with changes, rife with adjustments, and that can include, you know, sexual health as, you know, a whole, but also as a very important aspect of overall health and well-being. And so issues such as identity, you know, shift, perhaps if people are parenting or who identify as mothers, that can be a part of that. Relationships, intimacy, and sexual desire. So, you know, some of that has been shown in some of the qualitative literature, but again, it's very pieced. And so we don't really have, you know, a really kind of grasp of, you know, how those are experienced, as well as how they're interconnected. So going into the purpose and methods of my study. So I aim to explore how postpartum individuals in Nova Scotia experience their sexual health after birth, as well as how the experiences are influenced and negotiated through relations of power. So as many of you know, in terms of methodology and theory, the study was guided by feminist post-structuralism, and I also used feminist post-structuralist discourse analysis. So some of these main tenets, of feminist post-structuralism, a lot of it centers first on kind of identifying beliefs, values, and practices. People's subjectivity, people's agency can come in, and sort of where the main thing is looking at discourse. So that can be, social discourses, institutional discourses. And when I'm asked to kind of explain, what's discourse in one line, it's sort of that taken for granted. It's, the way things are, and sometimes we become, kind of blind to it in a way because that's just the status quo. And so with this research, I wanted to challenge the status quo, and that meant identifying discourses that were, influencing participants, emotions and experiences. So it's kind of, that's discourse kind of represents just, the way things are. We don't know sometimes know how that came to be or why that is, but it's there. And it's important to recognize if we're wanting to use research to deconstruct, ways of being, ways of living, to then, challenge and, hopefully have innovative solutions through that. So I used a purposive recruitment strategy. So I interviewed 11 postpartum individuals who were living in Nova Scotia, who are between 1 and 6 months postpartum. And, my reason for that in terms of the 1 to 6 months postpartum was, I really wanted to sort of capture participant experiences as they were happening. So that 1 to 6 month period was kind of, where there's a lot of change. The postpartum, period itself is defined differently. Some say it's the first 6 weeks after birth, some say 6 months, some say a year. So there is variance in terms of, how that is formally defined. But for the purposes of the study, 1 to 6 months kind of seemed to be the period where, changes related to sexual health were most prevalent. So participants were 18 years of age or older and living in Nova Scotia, as I said. And I didn't formally collect any demographic data. And so the purpose for that was to have, experiences or any relevant aspects of, identity come forward during the interviews. And so with that, again, it kind of happened to be mentioned in a lot of the interviews. I seem to have, a age range from 21 to late 30s. And people who were living across Nova Scotia. So I interviewed participants who spoke to the experiences of, being in a rural area, such as the rural South Shore, or up in rural parts of Cape Breton, and some who were living in urban areas as well. So again, it was sort of something that came up during interviews. So my research questions, my primary research question was looking at how postpartum individuals who birthed a baby experience their postpartum sexual health. And sub-questions into that included how postpartum individuals negotiate relations of power related to their sexual health, as well as how postpartum sexual health is socially and institutionally constructed through different discourses. So again, really bringing out that FPS lens. So in terms of results, so the key issues identified, these sort of titles represent the sort of 3 chapters within my findings. So the first focus sort of on being in the postpartum body and negotiating discourse. The second was about renegotiating the postpartum body and related to image, meaning, and function. And then the third was feeling connected through sexuality. So that's where desire, intimacy, and support came through, and kind of some of those more emotional aspects of postpartum sexual health. So I'll take time to review all 3 sort of separately. Beginning with the first, so being within the postpartum body and negotiating discourse. So this was something that, really, I think stood out in certain ways and was kind of, again, where the focus went in a lot of the interviews and what people brought forward. It was so enjoyable to interview participants. I absolutely loved the, stage of doing data collection. And it was just, I think, such a sacred space to hold, I think with hearing participant experiences. So anyway, how this was all shaped and how it kind of came to be was, again, a kind of a fun process at times in terms of, coming away with the data. And I remember kind of being, having, kind of nearly completed my analysis and just feeling that the data was, so rich. And I said, okay, how am I going to tell cohesive story here. There's so much here, which I'm sure some of you folks can relate to. So anyway, so focusing back on the first key issue. So the first sub-theme within that was personal knowing and choosing to re-engage in sexual activity. And so this kind of came a lot from, discourses that participants were aware of, and also kind of that they sort of described how, they wanted to or chose to trust their gut in terms of, knowing if and when they were physically and emotionally ready to engage in sexual activity, whether it was partnered or unpartnered. And so this, again, that personal knowing piece was really, where we kind of saw that power and the agency come out here, in terms of, participants hearing this. There were discourses that, strongly encourage sexual activity, in relationships, period, but even during the postpartum period. And so there was a lot of kind of negotiating, okay, I'm not feeling so ready. What is this? I think a big thing coming through was this need and desire to feel normal and to just have experiences normalized. And so personal knowing was a way of sort of, balancing, what participants were feeling